I think we can start with Dr. Prakhyat Roop's paper first. So Dr. Prakhyat will be talking to us on revolution in presbyopic correction beyond diffractive dichotomy. Dr. Prakhyat, please. Can you load Dr. Prakhyat's presentation, please?
Mic is on. Okay, thank you. So, good afternoon to the audiences and the panelists on the stage. I am Dr. Prakhyat Roop, and I am a practicing cataract, cornea, and refractive surgery specialist at Roop Netralaya in Meerut. I have a private practice, and I have a keen interest in optics, so that is how I stumbled upon this idea of refractive, diffractive technologies and innovations in that, and have been associated with a lot of such research in the past. So I'll be speaking about the refractive technology and the refractive, diffractive technology and how they are different, the two presbyopia correction optics that we have, the dichotomy that is there in between them. What is the edgeless phase matching technology, which is a completely different way of looking at the optics and using it for presbyopia correction. And then the clinical results with an IOL, which is the Naturo panfocal IOL, that utilizes this edgeless phase matching technology. The sources of information in my presentation, which I have not highlighted specifically, are from these four sources, that is the US FDA data, the company published data about IOLs, a study that I undertook in collaboration with Lambda X, which is a metrological analysis company in Belgium, and then independent studies done at IIT Delhi and at the Diffractive Optics Group at the University of Valencia in Spain, which is a world leader in terms of diffractive IOL optics. So if we look at refractive optics, to put it very simply, maybe oversimply, refractive optics involves one zone giving light to one particular focus. And so the pupil aperture controls the performance of a refractive lens, meaning that it depends on the size and the location of the pupil as to what area of the lens is exposed, and that changes the performance of the lens. Spherical aberration changes are basically changes in refractive power of the lens that are tightly in conjunction with the change in radius of curvature. So it is a mathematical correlation between the radius of curvature and the radial distance from the center. If we look at spherical aberration based lenses, which are the current day EDOFs and their power maps, we see that a spherical lens has a same power, while if we look at a negative aspheric lens, you will get a slightly lesser power in the center, slightly, or you can say more power in the center. And if we look at something which has modified asphericity to a large extent, that becomes somewhat like a zonal refractive lens, but with a large blending zone. So what it does is that if you look at a spherical lens, the light from the periphery gets focused in front of the light in the center. But if you look at a negative aspheric lens, then the light from the central rays is focused before the light in the peripheral rays is focused. And this is what we utilize to get an extended depth of focus. Now, while these lenses are very, very rewarding, they do have some limitations. So if we look at aspheric IOLs, then this is a very unique article that I saw on CRS Today Europe, where you can get 10 pearls for using a spherical aberration based lens for your clinical practice, which says that if an optical system has spherical aberration of 0, it gives in nighttime driving a 45 feet advantage in stopping distance at 88 kilometers per hour, meaning that if you have a spherical aberration in your optical system, then your stopping speed or the judgment gets delayed by that point. And If we look at spherical aberrations, they become active only at larger pupils, meaning that they are useful in younger patients mostly. If we look at diffractive optics, then it is a completely different way of using the light to get presbyopia correction, because one focus or one zone can give light to multi-orders. That is, it is not aperture dependent. Any exposed zone can give light to 2 or more foci. There needs to be constructive interference of light, for which the radius of zones is tightly controlled by a formula. And the height of each step determines the amount of light going to each focus. This divides our practice into a dichotomy, where on the one hand we have refractive or spherical aberration based lenses, and on the other hand we have the trifocals, which are diffractive lenses. The dichotomy is that while a trifocal lens will give an excellent range of vision, you will have problems in visual quality due to the loss of contrast and due to the night driving, halos, glare, starburst, ghosting of light, etc. Now the reason for this problem lies in the diffractive steps. So this is a patent application filed in 1998, which shows that actually light which is incident at these steps causes a lot of scatter and disturbance, which is the cause of all of our problems with trifocals. It says that light incidence from an off-axis point scatters at the steps, and the scatter increases with increasing angle of incidence, increases with increasing step height. And to solve this problem in 1998, before any diffractive IOL was implanted in the eye, it gave a solution. They said you align the light parallel to the incident light. But that is not possible in the human eye. So what is really the need for steps? The need for steps is necessary to match the phase of light to baseline. In simple terms, it is necessary for the IOL to function properly, and it is the best way to do that. At least that's what we knew. And this has been known to everyone right from the very first restore lens, and the reduction in step heights or step numbers has been utilized as a strategy to decrease the side effects. Currently, the most popular lenses either reduce the step height or reduce the step number to reduce this unaccounted light wastage. Now, why was there or why is there no assessment of this light loss to design features? The reason for that is that when you are seeing an IOL on the optical bench, the light is actually aligned parallel, like they said in that application, the patent application. So basically, you are not able to assess the light loss at all. But in real life, light comes in at a slanting angle, and it undergoes multiple optical phenomena at these edges, which causes all the ghosting and starburst and waxy vision. So the lab results actually don't take into account this light loss. And I tried to solve this problem in multiple ways, for which I applied for multiple patents, got granted multiple patents, but practically could not get a working prototype. The second thing that we should always look at is the defocus and MTF. So while a defocus tells you what is the Snellen visual acuity, an MTF tells you what is the quality of that image or what is the contrast sensitivity. In simple terms, MTF is contrast transmission. If you look at the top and the bottom image, the contrast is reducing from the left to the right, but the top image is deteriorating in quality while the bottom image is not. The bottom image signifies a Snellen vision chart. It is a square wave grating. But if you look at the top image, it signifies your real life situations, where it is a sine wave grating. So if you look at defocus only and don't look at the MTF, you will be confused. Why would you be confused? Is because in a monofocal lens, the MTF for distance is about 80-90%. The defocus says that the vision should be 6.6. In a trifocal lens, the best performing trifocal lens, the MTF is 40%. And the defocus says that the vision should be 6.6. But there is a significant difference in the image quality. Both are sharp, but both are not equally good in quality. So that is why we must look at the area under the curve. Now the question is, why is a patient happy with a trifocal? The reason is that cataract is even worse. The patient doesn't know that he could actually have a much better vision. Now comes to the rescue this amazing technology which introduces negative kinoform phase matching, which is basically saying that instead of having a base curve with a plus add, we have a base curve with a plus add with a minus add. So we have two different kinoforms that are aligned together, and that completely eliminates the edges. Now I did a study on this myself because I wanted to know if it actually diffracts light or not, and we got a ray tracing model made, and it actually made sense. So what happens is that this surface, which is the Lmax profile, it utilizes the complete optical element to give light to a useful focus while eliminating those edges that cause the waxy vision. And that increases the area under the curvature of the MTF curve. We have done about 500 eyes now, and 170 of them bilaterally. And we see that if you look at the binocular distance and intermediate and near vision, at all distances, it is good or better than 6/9. If you look at, I'll take just 30 seconds more. If you look at the distance corrected vision, it is absolutely phenomenal, comes close to 6/6 in almost all of the patients at all distances. If you see the presbyopia range, that is from 100 centimeter onwards to 33 centimeter, as you come closer, it tends to go close to 6/9, which is still better than N6 at all distances. If we look at the symptoms, then the only visual symptom that the patient complains is halos, which is basically having multiple foci, and that causes the patient some problems in about 1.2% patients. The night driving comfort is excellent. If you compare it to EDOF, it is absolutely comparable. Now, this is a very important slide where what we did is, we did a sub-analysis of 12 patients who were implanted with a trifocal IOL and were not satisfied with it. The main reason of being dissatisfied was because of the severe starbursts. And we implanted the other eye with Naturo, and none of them had any visual side effects in the other eye. So we have been using this lens for CLE a lot in post-LASIK patients, in patients who want some spectacle independence but have a monofocal aspheric lens in the other eye. And the patients are really, really happy with the quality of vision and the range of vision. Thanks a lot.
Talk, Prakhyat, and kudos to you that innovation is a difficult thing, and the small things make the quality of life enhancement in patients, and it's extremely heartening to see that you went along with it and brought the lens. Congratulations to you, and we recognize the extreme hard work that you've done. My question is, when you are considering which patient to implant, what is the talk that you have with them? How to understand and how to choose a lens?
Yes, so basically what I decide is, I ask the patient if they want spectacle independence or not. If they are comfortable with reading glasses, everybody knows, and this is going to stay for some time, that a monofocal aspheric lens that makes your spherical aberration 0 for the optical system is the best in quality. There is no doubt about it, like I said. If they want spectacle independence, then I go for Naturo. The reason is that I have shifted from enhanced monofocals and trifocals to Naturo because it requires less counseling. I don't have to look at pupil sizes. I don't have to look at angle alpha. I get predictable outcomes with complete range of vision. Side effect profile is good. So basically, practice has shifted more to it. And that's why probably I am doing so many more numbers of that lens.
Brilliant. Any comments?
Thank you. It's a brilliant work. I have a slightly different perspective to it. So what's your opinion on using these lenses in patients who have some retinal problem like rod cone dystrophy, retinitis pigmentosa, where macula is absolutely normal, but they do have some dark adaptation issues and
I would not use these lenses in those patients. The reason being that if you, like I said, in an optical system which is completely piston, all of the light is going to the retina. So you have to change the focus by using a spectacle, but for that particular point of regard, all of the light is going to the retina. If your retinal sensitivity itself is reducing and you're splitting the light further, then the quality of vision for the patient is deteriorating significantly. So I would not go in for that lens,
so
definitely.
How about high myopes?
That's a tricky question. So basically, I would go for my retina specialist's opinion in that regard, And if
Okay.
they say that, you know, the retina is quite thin, the outer bands are not that good, the choroid is very, very thin, it's almost like the sclera is right behind the retina, then we avoid it. Because even the ELP in a high myope is not that great. So overall, the outcome is not going to be very satisfactory.
Thank you so
That's the
much.
case with every premium lens, you know.
Makes a lot of